Good afternoon and welcome to this vote session for the House Health Committee. Today is Friday, February 20th, and this is vote list number 3. We're going to start with our withdrawals. We have second. All right. Is there any further discussion, questions, comments? All in favor on adopting the withdrawals, please say aye. Aye. Anyone opposed? Go ahead and raise your hands. All right. I am doing my first request to reassign. So I'm on House Bill 1022, PFAS chemicals, product phase-outs and registration requirements. Do I just make a motion? Motion to reassign? Second. All right. Any discussion? Yes, Delegate Hutchinson.
So I did talk to Lindsey Thompson this morning about this as we worked diligently on that PFAS bill last year. This does have an aspect that affects pesticides and PFAS. So it is snuck in there. She has requested an amendment to remove part of that language and is working with them. So I sit here still with some reservations that we're allowing it to be reassigned when this committee said, don't bring it back. And it's going to ENT now with an aspect that does affect crop life and
it's jointly assigned.
All right, so
yes, just to clarify, we will continue to be jointly assigned. We're trying to reassign the primary because there are two partner bills. Okay. And I will say I talked with the analysts and one of the bills was ENT with health second and one was health with ENT second, and they both were basically 50-50. So the analysts said they went one way on the one bill, one way on the other bill, but we will continue to have a role in that bill.
Okay, I would like to request that I am one of the committee members that works on that bill.
I would have it no other way. because this committee did a lot of really important, meaningful work on that bill last year. Delegate Riley.
Yeah, I have a question. So when we're second, will we be able to see the testimony on our laptops? I can't remember if we can or not.
I don't.
Because right now you can't see it.
Right. I don't think we can see it on our laptops, but we will get the folders, and we always get a folder.
Well, can you make sure that that's scanned and every member here can get a copy of that? Because we did do a lot of work on that bill last year. And
we did, and so
It is normally the 3 people who go.
It is normally the 3, but I will make the request to make sure our entire committee
so that we get the testimony.
Gets
Thank you very much. I appreciate it.
Yes, we will put that on the record that we will make sure that our entire committee will get a copy of the testimony. Any further comments on reassignment? All in favor say aye. Aye. Anyone opposed? Yeah, that's fine. We will record. We are reassigning not unanimously. I had Delegate Hutchinson and Delegate Riley. And Delegate Chalega. And Delegate Warman. I understand and I appreciate because these are the folks that were on the work group. Delegate Kipke.
Really?
From them or from us, their things, are we gonna be limited? If they pass it out? Affects us, because I've had bills where the secondary committee completely held it even though it passed out of the primary committee. We tend not to do that here.
We will continue to have an important role. I have spoken with the chair of the other committee. I've spoken with the bill sponsor as well. All right, let's do it this way. Let's do it this way. Delegate Alston, I will remind you this is my first reassignment in this role. And we want it to be memorable, exactly. And I will say, I spoke with the bill sponsor who, as this committee knows, worked diligently with us last year. And I did speak with the analysts, and there is an important component to this bill, which is this water restoration fund, which really is solidly in the other committee. So I want to make sure that we're recording our votes correctly. So let me start with all in favor. Let's go ahead and just raise our hand. All in favor of reassignment. I've got Lopez, Gazzoni, Kaufman, Rosenberg, Cullison. Don't think I'd vote. Oh, Alston, Alston, yes or no? Yes. No. Okay. Johnson, Taveras, Delegate White Holland and Riley, Ross, Martinez. All opposed? Oh, yeah. I was going to say, we can record Kathy opposed. Yep, thank you. Morgan, Warman, Kipke, Hutchinson, and Riley.
Yeah, so when you say Riley, it is a little.
Oh, I'm so sorry. Thank you. Thank you. Yes. So Minnie. Yes, thank you. Thank you for the clarification. Yes, baby Riley. Delegate Riley and baby Riley. All right, so the motion carries. Are there any abstentions? Delegate Hill. The motion carries with 6 opposed and 1 abstention. All right, thank you very much. Now we are getting into the meat of the matter. I've got to mark so I don't get lost. All right, House Bill 276. This is State Emergency Medical Services Board Public Access Automated External Defibrillator Programs revisions. This was held from the last session. Oh, you know what? We're going to not do this bill right this second because Delegate Shalega is not yet. So we'll go to the next bill and then come back. Because I want to make sure that she's here for the discussion. House Bill 322, Maryland Health Care Commission membership. This is Lindsay and Delegate Gazzoni.
This bill alters the membership of the Maryland Health Care Commission by reducing from 9 to 8 the number of members who do not have any connection with the management or policy of a healthcare provider or payer, and then adding 1 additional member to be, as originally introduced, a representative of a hospital. So that's keeping the total number at 15. And then when appointing members of the commission, the governor must assure that at least 4 rather than 5 members are residents of different counties with a population of 300,000 or more. On page 9 in your packet is an amendment adopted in subcommittee which requires the representative of a hospital added to MHCC to be an administrator of a hospital. This conforms the bill with the cross file that passed the Senate 44-0.
I don't really need to say anything. It was unanimous in committee.
The amendments have been moved and seconded. Any further discussion on the amendments? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, bill has been moved and seconded. Any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, that passes unanimously. This is our first non-departmental favorable with amendment. All right. House Bill, we're going to go back to House Bill 276, and this is State Emergency Medical Services Board Public Access Automated External Defibrillator Program revisions. This was held from last week. This is Lindsay and Hill.
This is a departmental bill from MIMS that alters the Public Access Automated External Defibrillator Program, the AED program, by clarifying which entities are required to participate in the program, exempting a law enforcement agency from obtaining a certificate for an AED deployed in a patrol vehicle, codifying the role of an AED coordinator and establishing specified requirements for the coordinator, repealing obsolete provisions related to regional councils and regional council AED committees, and making conforming and clarifying changes. There's a reprint of the bill on page 1 in your packet with the amendments adopted in subcommittee that establish that for a grocery store or restaurant to qualify for and retain a certificate, the entity needs to register the name of the entity with the program and maintain the functionality of each AED and related equipment and supplies with FDA standards. Also, earlier this week, there was a letter circulated to the committee from MIMS that addressed questions that were raised last voting session on this bill. There was a question about the list of program participants and the types of facilities that participate in the program. They do have a list. They didn't provide it. There are currently more than 17,250 AEDs registered as part of the program, they said, so that would be a very long list had they provided it. There was a question also about the role of the AED coordinator, and that's why I emphasized the word codifying. They said that the AED coordinator has actually been a requirement in regulations. They're putting this in statute. So they don't think that having the AED coordinator is in any way a deterrent to participation in the program. There was a question about certain entities, whether or not they're required to participate in the program. The example is a dress shop. A dress shop's not required to have an AED if it's an optional for something like a dress shop. The General Assembly adopted legislation requiring grocery stores and restaurants of a certain size and with certain revenue to have AEDs. There's also a requirement in state law for middle schools and high schools to have AEDs, and for county and Baltimore City libraries to have AEDs. And there's an exemption now from the AED program for AEDs that are like in health facilities or in doctors' offices, things like that, and they're adding the AEDs and patrol vehicles to that list through this bill as well.
Delegate Hill.
I think Lindsay's summarized the information. The question, Delegate Shalega, does that answer your questions?
So this is exempting police, grocery stores, and restaurants. But if we think it's worthwhile exempting them, why don't we exempt everyone else?
Just to clarify, it's not exempting the grocery stores and restaurants. Grocery stores and restaurants actually of a certain size do have to have an AED. That's provision in state law now. So this is clarifying how they comply with the requirements of the program. Because the way the AED requirement for grocery stores and restaurants was written, it wasn't actually included in this particular section outlining the program. So it's clarifying how they register, which is essentially just, and this is what the amendment does. It says that they have to register the name of the entity with the program and then maintain the functionality of their AED. But this way, when EMS is deployed, they know that there's an AED on premises that they can use if they need to.
And if I may, the reason that police vehicles are excluded is because the training that they receive is thought to already mean that they know how to respond should there be an emergency, so they don't need to, they're already under other obligations to do what they need to do and to make sure. So when I think about the AED, I mean, I think you raised the question, would this diminish the number of AEDs in the community, right? With the dress shop decide that even though in regulations I needed to have someone, now that it's in statute, I don't have anyone to name, so I'm not going to have an AED. The way I look at it is if you have an AED and you're not keeping the pads, or you're not keeping it charged, you're not having the batteries, I'd rather that you say I can't participate and take it out than have my mother or you or someone else have an incident and I go running to an AED, wasting valuable time trying to get something to work that doesn't work. It's kind of like a fire extinguisher. If I run out to get the fire extinguisher, I want to know it's working. So if you can't do it, then please don't volunteer to do what you can't do.
But you're making people do it.
No, we're not. No, that's the whole point.
So you're making, so not you, the state of Maryland is requiring grocery store, this was the kind of the question I had before. AED requirements are for, of course we get medical, I'm not worried about them. If somebody has a heart issue, they certainly have qualified people there to do it, and, police officers are trained as well. But grocery stores and restaurants are, by state law, required to have an AED.
Right, from previous bills that we passed,
Right.
correct.
Who
correct.
else? That was my question I asked. And you said there's 17,500.
But they're not required to have an AED.
The only people in the state that are required to have an AED, can you confirm that, are police, hospitals, restaurants, and grocery stores?
Middle
So
schools.
middle
high
schools and high schools, there's
Okay.
provision under the education article for the, the county boards. The county boards are required to have an AED program that mirrors this one, essentially, for middle schools and high schools. There's a requirement for the county libraries and the Baltimore City Library, so all of the libraries, not just one, in the counties have to have an AED. And then the requirement for grocery stores and restaurants, this is from 2023. The grocery store has at least one of the major food departments, which are produce, meat, seafood, dairy, canned and packaged goods, at least 12,000 feet of floor space, and an annual gross income of and it doesn't apply, if it has an annual gross income of $10 million or less. And then for a restaurant, they're exempted if it's an annual gross income of $1 million or less, exclusive of sales for off-premises consumption, or a seating capacity of less than 100 individuals. So essentially, big grocery stores, big restaurants.
Okay. And so this bill will put them on a different requirement than the libraries, the schools, the other people you outlined.
Could you state your question again? I didn't really understand.
So with the amendments, they will not have to have as strict of guidelines as the libraries and schools.
I'm not sure what you mean by as strict of guidelines.
So what were the amendments for grocery stores and
The amendments, I'm sorry, I'm not
and,
looking in the packet.
restaurants.
Let me look in the packet so I can look on the page that you're going to be looking at. So if you're on page 5 in your packet, for an entity that is a grocery store or restaurant to qualify for and retain a certificate, the entity shall register the name of the entity with the program and maintain the functionality of each AED and all related equipment and supplies in accordance with the standards established by the device manufacturer and the FDA.
So there was something in the original bill, and maybe it was amended, that requires anyone with an AED to have a person they name in charge of it and a program that goes with it. Where would that be? Certificate? No, that wasn't it.
It's above it.
So the AED coordinator is
That's it.
new law in the statute. The definition of AED coordinator appears on page 2 in your packet, lines 6 through 8. It's the individual designated by the registered entity to ensure compliance with the requirements of this section. What MIMS is saying is this is from COMAR. They're putting it in statute. So they've already been asking these folks to have someone who's responsible for ensuring compliance with the program.
And I see where it is, lines 17 to 19. The coordinator has to promote awareness, location, operation. Okay. Well, thank you for taking the time to answer my questions. I appreciate it.
Absolutely, and we want to make sure everyone is clear on what we're doing. So just to further clarify, the 17,000 that you spoke of, those were voluntarily participating in the program, is that correct?
So it's not delineating
not
between anyone
delineated,
who's
but-
required to or not. So largely
Largely.
volunteerism.
Largely volunteering. I don't think we've moved the amendments. Do we have a motion on the amendments? All right, they've been moved and seconded. Is there any further discussion on the amendments? All right. Seeing none, all in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, do we have a motion on the bill as amended? All right. It's been moved and seconded. Now let's open it for discussion. Delegate Morgan.
Thank you, Madam Chair, and I guess this question is for Lindsay. So there's 17,000 and some amount of participants on an AED, and now all 17,000 of them are going to have to register a person? Is that my understanding that correct?
So
Or what percentage?
Their registration already, they're registered with the program. So that's so that the program knows where the AEDs are. Again, I think the main purpose is so that emergency personnel are aware of the presence of one. It doesn't mandate that they even use the AED. There's immunity provisions that say they're immune from liability if they use the AED in good faith or fail to use the AED.
They just have to designate a person.
Complying with it. Yeah, so they're designating a person.
Delegate Ghazzani.
Thank you. I just want to be clear, it doesn't necessarily need to be like Joe Smith. It could be the manager of the store or the person who does, whose job is assistant manager or whatever like that.
That's not specified. It's just the person that's designated. So it could be the manager of the store. It could be part of one person's job description.
Delegate Shalega.
Thank you. So I found the answer to my question. I just thought I would share it make sure I'm reading this correctly. So on handwritten 5, for grocery stores and restaurants, we are saying that they have an AED, and what they're responsible to do is maintain the functionality in accordance with the standards, which is fantastic. But then we're saying everybody else has to have a coordinator who will promote awareness, location. That's kind of where I was going before. Why don't we just say everybody who has an AED should do what we're letting grocery stores and restaurants do? And so for those reasons, I am going to vote against the bill. Thank you.
Any further discussion on this bill? All right, seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hands. Delegate Shalega, Delegate Morgan. All right, and it passed not unanimously. Thank you very much for the discussion. House Bill 372, this is hospitals, emergency pregnancy-related medical conditions procedures. This is Lindsay and Ghazzani.
This bill generally codifies the Federal Emergency Medical Treatment and Labor Act, also known as EMTALA, in state law as it relates to an emergency pregnancy-related medical condition. If a hospital determines that a patient has an emergency pregnancy-related medical condition, the hospital must, using the staff and facilities available to the hospital, provide further examination and the treatment required to stabilize the emergency pregnancy-related medical condition, including the termination of a pregnancy when medically necessary to stabilize the patient or transfer the patient to another medical facility. A hospital must allow the termination of a pregnancy at the hospital if the patient's treating healthcare practitioner determines termination is medically necessary to stabilize a patient. A hospital is prohibited from taking specified adverse actions against a provider for not transferring a patient who is not stabilized or against a hospital employee who reports a violation of the bill. The bill establishes civil penalties based on bed capacity, and there were no amendments adopted in subcommittee.
Delegate Ghazzani.
Sure. In subcommittee, we had a good discussion about this. There were no additional amendments, and it passed on a 5-2. Actually, it might have been 4-2 because I'm not positive if Delegate Ross was with us at that time. There were 2 people who voted against it in committee.
Delegate Alston.
It's actually not about the bill. I just didn't want to forget before we get into the discussion on this one that you mentioned on 322 that was the first bill we had favorable with amendments, but we didn't do the second step of asking who wants to be on the bill. So I just don't want to forget it because I feel like this discussion is about to maybe get a little interesting.
All right, so are you requesting a?
I'd like to be on the bill.
Is this on the hospital?
322.
Yes.
All right, so, oh, sorry, I need to turn my mic on. So we are going to pause 372, go back to 322. You wanted to make a motion for a sponsor amendment? Yes. All right, so House Bill 322, no, so I'm sorry. Yeah, 322. Okay, the Maryland Healthcare Commission membership, or the one we just discussed, the state emergency medical? Oh, yeah, okay, 322. So, thank you. Anyone who wants to be on? Okay, oh, yes, thank you. Is there anyone who does not want to be on House Bill 322, the Maryland Healthcare Commission membership? Go ahead and raise your hand. Does not. Does not. Yep. Yep. Yeah, yeah. This is not the defibrillator bill. This is delegate, this is the Healthcare Commission. All right, so everyone will be on that bill. And thank you Delegate Alston for the reminder.
But I will note 372 does not have a
Oh, so Delegate will not be on 322. Got it. All right, thank you very much. Going back to 372, Delegate Gazzoni has, Lindsay has explained the bill, Delegate Gazzoni explained the subcommittee. Do we have a motion on the bill? Move the bill. Second. It's been moved and seconded, so let's go ahead and open it up for discussion. Is there any discussion on this bill? Seeing none, we have a motion. All in favor say aye. Aye. Anyone opposed, go ahead and raise your hands. We have. It has not been amended. Okay, on the bill, yep. Yep, on the bill. So I have Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. So the bill passes not unanimously. Thank you very much. House Bill 373. It's favorable. There's no amendments. It's no amendments.
Sorry.
Yeah. House Bill 373. This is State Board of Dental Examiners Disciplinary Action in Unannounced Inspections. This is Lindsay and Rosenberg.
This bill authorizes the State Board of Dental Examiners to conduct an unannounced inspection to determine compliance with the Centers for Disease Control and Prevention's guidelines on standard rather than universal precautions and guidelines for infection control in dental healthcare settings under specified circumstances. The bill updates and alters grounds for disciplinary action by the board and authorizes the board to take disciplinary action against or relating to an expanded function dental assistant. There were no amendments adopted in subcommittee. This was in Health Occupations.
And Rosenberg.
No amendments, and this bill was voted out unanimously.
All right, bill's been moved and seconded. Is there any further discussion on this bill? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hands. All right, the bill passes unanimously. We are now on House Bill 380, State Board of Examiners in optometry, examination requirements and time period in inactive status. This is Lindsay and Rosenberg.
This bill clarifies examination requirements for licensure and reinstatement under the State Board of Examiners in Optometry by specifying that an applicant for licensure or reinstatement must pass all sections of each part of an examination, and the board must determine the passing scores for all sections of each part of an examination. The board is prohibited from placing a licensee on inactive status for more than 6 consecutive years. The bill also repeals the requirement that the board give examinations to applicants not more than once every 6 months and notify applicants of the time and place of the examination, and that an applicant pay a re-examination fee to take the licensure exam. There were no amendments. This was in Health Occupation Subcommittee.
Delegate Rosenberg.
This was also unanimous. I would move favorable.
All right, it's been moved and seconded. Any further discussion on this bill? Oh, Delegate Shalega.
Thank you. So I was thinking about this as a member of the Veterans Caucus, and on page 4 is where the language says the board may not place the licensee on inactive status for more than 6 consecutive years. I wonder, thinking about the military, my family, we moved a lot, and then we were in Maryland, out of Maryland, eventually, came back to Maryland. How could this affect a military personnel or spouse that had their license on inactive, and they want to come back here and practice? Should we put an amendment in there that would say, the board can redetermine if it's, military spouse or personnel? Yes, we're not shutting the door to military that could, we have a lot of military here, so just my thoughts when I was reading the bill.
So I'll say that the board did note that this is pretty standard language across the other health occupations boards as well. The reason being that if you've been out of the workforce for a little while, they're concerned that you're not sort of keeping up to date with the requirements. I'll also note that all of the health occupations boards are required to have an expedited process to license members of the military and their spouses. And they also are required to assign a person to help facilitate that, not just that they say that they're going to do it within 15 days, but they also have someone to help facilitate doing the application process. So if you wanted to get re-licensed, you can do it relatively quickly. So I think that that's sort of the main way that that's addressed in current law.
I guess I would just say their license may be inactive, or could it be? I don't know how the license program works, but, you know, if an optometrist left, would their license then just naturally be inactive because they weren't here, and then they came back? Would they then have to, because after 6 years, would they have to re-qualify through everything? I'm not trying to be an obstructionist. I'm just thinking about, that we just heard the bill about helping, all of the licenses. I was jointly assigned with you. Yeah, Delegate Rogers' bill. So,
So I think there's also a little bit of a distinction between if you've applied for inactive status in Maryland or if you are actively practicing somewhere else. So that would be that you have an out-of-state license. And there's also procedures for expediting out-of-state licenses, getting licensed in the state. So this would be up to the practitioner if you're trying to maintain an inactive status license in Maryland, or if you just allow your license to lapse, and then if you come back, you would apply for a new license. And that's the reference that I was making to expediting the process of getting your license if you have just let your license lapse. But if you're practicing in another state, then that inactive status may or may not apply if you have not opted to keep an inactive status license in Maryland.
thank you.
Delegate Alston.
I just wanted to get clarity. I'm good with the part where they have to pass all 3 sections. What I'm not clear on is it says the board can determine the passing score. So does that mean that the board can pick a passing score that's below 70% and say this is your passing score?
Don't specify what they would have to pick as the passing score.
So the board can pick any score it wants? It's not the national passing score standard for the test administrator?
We might be able to talk to the bill sponsor. Was that part of the discussion? Delegate Johnson?
Was part of the discussion, and it went back and forth, and this is how the current posture of the bill is how it passed in the Senate, and the parties said they were okay with that.
So this conforms to a bill that's already passed the Senate?
Correct.
43 to 0.
Passing it. Delegate Alston, do you have outstanding concerns?
I just wouldn't want to see them saying, like, you can pass all 3 sections with a 60% and then that's considered passing. Because it doesn't say, like, are we doing this on a curve? And I'm not trying to get too deep in the weeds on it, but it does concern me that the board is setting the score. They're saying you have to pass all 3 sections, and then they set the passing score themselves.
I will say, having worked with our state boards of examiners, I have not found them particularly on the liberal side of scoring. So I hear that concern. I think, given our experience with our boards, I think that probably it's going to be on the other side.
Okay.
But I appreciate the discussion.
Yep.
Is there any further discussion on this bill? And was this, and this is, there are no amendments, so we're just on the bill. So on the bill, all in favor say aye. Aye. Any opposed, go ahead and raise your hands. All right, seeing none, that passes unanimously, and there are no amendments. So next bill is House Bill 393, not 939. House Bill 393, this is Health Insurance Scalp Cooling Systems Required Coverage. This is Lisa and Cullison.
This bill requires carriers that provide coverage for chemotherapy to treat cancer to provide coverage for scalp cooling systems used for the preservation of hair in connection with the chemotherapy treatment. There are no amendments.
I'll second. In the subcommittee, it was voted unanimously, and there were no questions or discussion. So, second, the motion to move the bill.
The bill has been moved and seconded. Is there any further discussion on this bill? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Oh, and we've got Delegate Shalega, Delegate Morgan. So it passes not unanimously. And it is not amendment, so. House Bill 422 is Public Health Expedited Partner Therapy, Bacterial Vaginosis. This is Lindsay and Rosenberg.
This bill adds bacterial vaginosis to the list of conditions for which antibiotic therapy can be provided to an individual under the state's Expedited Partner Therapy Program. The program is the practice of providing antibiotic therapy to the sexual partner of a patient diagnosed with certain sexually transmitted infections without an intervening medical evaluation to stop the further spread of the infection and reduce the likelihood of reinfection in the patient. There are amendments that are on page 10 in your packet, adopted in subcommittee, that update terminology and add licensed certified midwives to the list of healthcare practitioners who may provide antibiotic therapy under the state's Expedited Partner Therapy Program.
Move the amendment.
All right. Rosenberg, it's been moved and seconded. The amendments, any further discussion on the amendments?
Those amendments were adopted by the subcommittee, so it support the amendment.
Thank you very much. All right, seeing no further discussion, all in favor of the amendment, say aye. Aye. Anyone opposed, go ahead and raise your hand.
Move the bill. Second.
Bill's been moved and seconded. Is there any further discussion? All right, seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right. Delegate Taveras, would you like a sponsor amendment? So anyone who would not like to be on this bill, go ahead and raise your hand. I have Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. All right, thank you very much. House Bill 442 is professional liability insurance coverage, nursing homes, assisted living facilities, and nurse midwives disclosure. This is Lisa and Cullison.
This bill requires each nursing home, assisted living program, and nurse midwife to provide notification if professional liability insurance coverage is not maintained or such coverage has lapsed or not been renewed. Each nursing home, assisted living program, and nurse midwife that does not maintain professional liability insurance coverage must post the information in a conspicuous location. There are amendments on page 12 of your packet. The amendments make technical changes, and they require licensed certified midwives to provide the notification and comply with the posting requirements of the bill.
Move the amendment. Second.
Are you good, Madam Vice Chair?
I am good.
On the
The
amendments?
sponsor was good with the amendments, and the bill was unanimous as amended in the committee.
All right, any further discussion on the amendments? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended.
Move the bill.
Second. Bill has been moved and seconded. Anyone, any further discussion? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Is there anyone who wants to be on this bill who's not on this bill? Anyone who does not want to be on this bill? Go ahead and raise your hand. Delegate Shalega. All right, thank you. Now we are on to House Bill 494. This is Health Insurance Primary Care Investment Targets Reimbursement. Oh, 445? Oh, did I miss one?
445, yeah.
Oh.
We just did 442.
Oh, wait a minute, okay, sorry, yes, I've messed up my own check marks. So 445, thank you, Maryland Medical Assistance Program and Health Insurance Coverage for Orthosis and Prosthesis. Oh my gosh, how could I miss this one? So everybody can move, I got so excited about it. This is Lisa Ann Cullison.
This bill alters the current mandated benefit for coverage of orthopedic braces to be coverage for orthosis and replacement of orthosis, and clarifies the mandated coverage requirements for prosthesis. There is an amendment on page 15 of your packet, and the amendment alters the definition of orthosis to include devices used to treat congenital conditions.
All right, Vice Chair Cullison.
The amendment was okay with the sponsor and passed the committee unanimously, so we can vote on the amendment.
Is there any further discussion on the amendments? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand.
Move the bill as amended.
All right, it's been properly moved and seconded. Any further discussion? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Sorry. On the bill as amended. So Delegate Morgan.
Thank you, Madam Chair. I just want to point out in the fiscal note, just the same reason why I voted no on the scalp cooling, which I am terribly sympathetic for anyone that's in that situation. But it's in the fiscal note, much like this bill and the last bill, the scalp cooling bill, it says under Maryland law, there's more than 50 mandated health insurance benefits that certain carriers must provide. So there's 10 Obamacare or ACA, depending on where part of the state you refer to that, as mandated coverage. And then the state of Maryland adds over more than 40. And I just have concern that another mandated insurance coverage adds to the cost of insurance. So I'm certainly sympathetic for the cause here and for the bill sponsor to do this. It's worthwhile, but I'm concerned about the cost, so I'll be voting no. Thank you.
Thank you very much. Any further discussion on this bill as amended? Vice Chair Cullison.
Thank you, Madam Chair, and thank you, Delegate, for raising that concern, because it is certainly one that we need to be aware of and appreciate. I will say that in many cases, for example, in the scalp cooling mandate, there is evidence that there will be money saved, that there'll be some savings offset. And I think that's one of the things we look at in some of these bills as we move forward. But I would ask us to be very judicious and aware of the concern that you've raised. So thank you.
Thank you very much, Madam Vice Chair. Any further discussion on the bill as amended? All right, seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan. So the bill passes not unanimously.
Can I add my name myself as a sponsor? Just give it a good time, Madam Chair.
Absolutely, thank you for, is there anyone who does not want to be on this bill? Delegate Shalega, Delegate Morgan. All right, thank you very much, and thank you for keeping me honest, everyone, because I messed up my own notes. House Bill 494, this is health insurance, primary care, investment targets, reimbursement, and reporting. Lisa Ann Cullison.
This bill requires an individual, group, or blanket health insurance policy or contract delivered or issued for delivery in the state by insurers, nonprofit health service plans, and health maintenance organizations to provide reimbursement to healthcare providers in a manner that meets the annual primary care investment targets established by the state on or after February 1st, 2026. There are no amendments.
Vice Chair Cullison.
Thank you, Madam Chair. So this bill is related very significantly to our ongoing work to be reasonable around hospital costs and healthcare costs in general. It's the AHEAD model requires a lot more engagement with primary care. There is lots of documentation and evidence that if people are taking advantage of primary care and preventive visits, then the healthcare costs go down because they don't become sicker. So the Maryland Insurance Administration is working with the Maryland Health Department, with the Maryland Health Care Commission, and the HSCRC to set the targets. No no payers are eligible, are required to meet these targets until they are developed. And I did ask that the payers, the carriers, be given the opportunity to participate in the discussion around what the targets are. So with that, the bill passed unanimously as amended, and no, it wasn't amended. And I would move the bill.
All right, the bill's been moved and seconded. Any further discussion? Seeing none. Oh, Delegate Morgan.
Thank you, Madam Chair. Does this affect reimbursement rates for the hospitals, correct?
No, it doesn't.
So there wouldn't be any rate hike or anything? I thought this bill was originally triggered off of executive order from the governor. Or am I mistaking this bill?
That, I'm not certain about an executive order, but it was the order, if there was one, it was around making sure that we incentivize those in primary care. But this is not raising rates, reimbursement rates, it's just reporting how much of their expenditures are going directly to primary care services. So that we as a state have an idea how we need to make sure that people are taking advantage of it.
Okay, I thought there was something that would have possibly driven more people onto Medicaid from this, but there's no mandate in this
No.
bill. Maybe I'm getting my bills confused. Thank you, appreciate it.
Thank you for the discussion. Delegate Shalega.
Thank you. So this, if I understand it correctly, will require, this is the MIA's testimony, requires certain entities to provide reimbursement to healthcare providers in a manner that meets the annual primary care investment targets. So is that kind of what Delegate Morgan was saying?
Right. So the targets will be set. We don't know what those targets are, though, at this point. So I guess you're right, it's potentially
Yeah,
increased
and it says
reimbursements.
further, commissioner, meeting the annual primary care investment targets to the MIA, commissioner when filing premium rate changes. So is this going to increase healthcare insurance rates?
They're going to take into consideration when they're setting the rates for the hospital global budgets, they're taking these rates into consideration. Those are always going to affect, under the current model that we have, will affect premiums. So, they're being considered.
They're going to set targets for primary care, force people there, and that might affect the rates going forward because more people will be going to their primary care.
Right, exactly.
Okay, I think I understand it. Yep.
So it sounds like this could very well increase insurance rates.
I think.
Depending on what the targets are.
Depending on what the targets are.
So-
right. And also, remember, the cost of primary care is a lot less than
Sure.
hospitalization. So again, we're having that, we believe there'll be an offset.
Delegate Kipke.
I was confused from when I read the fiscal note. And in the opposite of what normally happens when I read the bill, which is very tiny, I had complete clarity. And I might, maybe we could hold this to the end of the calendar, just it won't take long to read. There's like 5 lines. Thank you.
We have a motion to move this to the end of the calendar. Is that, and I don't know if we even need to take a vote on the motion, but we'll move this to the end of the calendar so we can have that discussion. And so that's going to be House Bill 494 we'll come back to. So we're now on House Bill 498, Certificate of Need Intermediate Healthcare Facilities. And this is Lindsay and Gazzoni.
This bill repeals the current exemption from a certificate of need for a change in bed capacity at an intermediate care facility that offers a residential or intensive substance-related disorder treatment services and has a current license issued by the Secretary of Health. Instead, the bill specifies that a CON is not required to establish, operate, or change the bed capacity at an intermediate care facility that offers medically managed residential substance use disorder treatment services if written notice of the intent to establish or operate the facility or change bed capacity is filed with MHCC at least 45 days in advance, and MHCC finds that the proposed facility or change in bed capacity is not inconsistent with the state health plan, will result in the delivery of more efficient and effective healthcare services, and is in the public interest. So basically, for a change in bed capacity, it's not a full CON process, but it's a streamlined review by MHCC. There are no amendments.
Delegate Kazani.
This was voted 5-1 in subcommittee, so one person was not in favor.
Would you like to move the bill?
Please.
Bill has been moved and seconded. Is there further discussion on this bill? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Just let the record reflect that.
She's already voted for the bill.
She's already voted, okay. All right, so that passes, and that is favorable. So next is House Bill 529. This is Code Revision Health Maryland Medical Assistance Program. This is Chris and Hill.
This bill revises, restates, and recodifies the laws of the state related to the Maryland Medicaid program. The bill clarifies language and makes technical and stylistic changes, and there were no amendments.
Delegate Hill.
Thank you, Madam Chair. No amendments, no significant, no concerns, no discussion, no abstentions, no negative votes, unanimously voted out of the committee. Let me think. Yeah. I'd like Delegate Kifke to move the bill because he's good at, I like his voice. Thank you.
All right, it's been moved in. Do we have a second? All right, it's been moved and seconded. Any further discussion? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, that passes unanimously. We're now on House Bill 535. This is Food Establishments, Cottage Food Businesses, Maximum Annual Revenue. This is Christopher and Hill.
This bill increases the annual maximum revenue for a cottage food business from $50,000 to $100,000, and there were no amendments.
All right, it's been properly moved and seconded. Anything else, Delegate Hill? All right, it's been moved and seconded. Any further discussion? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, and that is a favorable. So we are now on House Bill 599. This is Health Licensure of Hospitals Ownership Requirements. This is Lindsay and Gazzoni.
This bill requires a hospital, in order to be licensed on or after October 1st, 2026, to qualify as a nonprofit organization under federal law and be registered as a nonprofit organization with the state. A hospital licensed on or after October 1st, 2026 must maintain status as a nonprofit organization as a condition of licensure, and ownership of a licensed hospital may be transferred only to a nonprofit organization. This had no amendments.
Delegate Hill.
Spoke moments ago. On my, on HB 498, that was actually unanimous in subcommittee. This is the one where we had one person against in subcommittee.
All right, thank you.
My apologies.
That's all right. You know, we always good to clarify the record. So this was, this passed subcommittee not unanimously. All right. And this is favorable, so do we have, yep, move the bill, and it's been moved and seconded. Is there any further discussion on this bill? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. We've got Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. All right, so that passes not unanimously. And now we are on House Bill 672, Delegate Shetty and Rosenberg, Public Health, Maryland Pediatric Cancer Fund, entities eligible for grants. This is Christopher and Hill.
This bill alters the entities eligible to receive grants for conducting pediatric cancer research from the Maryland Pediatric Cancer Fund to include only nonprofit hospitals educational institutions, and other nonprofit organizations, laboratories, and persons are no longer eligible for grants. There was one amendment found on page 16 of the packet, and it just makes the bill an emergency measure.
There was no controversy. The bill passed unanimously with the amendment. I'd like to move the amendment.
All right, it's been, the amendment has been moved and seconded. Do we have discussion on the amendment? All right, all in favor of the amendment, say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Delegate Shalega.
Why are we not allowing them to give grants to physicians working on this?
So I don't know why we're not. It just wasn't what the task is that they were set up to do, and they didn't ask to have that ability.
So this now only can go to, can you restate it for me, please, Delegate Hill, hospitals with the amendment?
No, the amendment just makes it an emergency bill. This was the funds. Right. Yeah, okay, got confused there for a second. This allows the money to roll out faster. They've been sitting on this money for a while, and it hasn't been able to roll out. And by making it an emergency bill, they can start acting on those grants immediately.
So it's striking, after making distributions onto page 3, taking out eligible physicians and laboratories and people conducting cancer research. Why would we not want to support physicians doing pediatric cancer research?
I don't know. You're not talking about the amendment. You're talking about the bill itself.
We passed the amendment. I'm fine with that.
Okay, yeah. That was the request, and I assume that it's because it allows them to move things faster. The physicians generally are, most grants that go out for research go out to the parties, and the physicians aren't getting the grants except for the research. So if they're doing the research, the grant goes to the research they're doing, not to them personally. And I think, Chris, maybe you can explain why, in terms of the statutory language, the difference between a grant going to an individual as opposed to the grant going to the research project.
I mean, at this point, I'm really only assuming what the intent is from the sponsor, but I think the language taking persons out would, like you said, stop it from going directly to an individual and more to the organization or the hospital itself.
And I believe from the bill sponsor and the discussion with the analysts, part of the issue and the reason for the bill is that it was drafted in a way that did not actually give us the ability to distribute the grants because there wasn't an organization, and the intent was for it to be nonprofits, because those are we don't have any for-profit hospitals in the state of Maryland that would be eligible to do this work because they're not doing the work.
So, Madam Chair, I think Delegate Shalega, if you go to the fiscal note and you look under, on the first page, the second paragraph, current law, each year the Secretary of Health may distribute funds from the fund to a promotional account to be allocated to a state-based childhood cancer organization for use in promoting further donations to the fund and to educate the state scientific community about the opportunities for childhood cancer research through the fund, and use funds from the fund to administer the fund, including staff and administrative costs associated with the Pediatric Cancer Research Commission. And I think that because the staff are included, you don't have to specify, and it was redundant and confusing to specify directed fund grants to the physician. And I think they just wanted to be clear, we're not funding physicians, we're funding the research.
Okay, thank you. And I notice on the, there's $2.5 million in the fund right now. So it's not being funded at the rate the bill specifies, but,
They testified they hadn't been able to, that there was so much confusion about the way the statute was written that they had not been able to distribute. And that's why we made it the emergency bill, because they'd like to get the money out. We'd like them to get the money out, and we didn't want to wait until later in the summer.
thank you.
Thank you for the discussion. Delegate Johnson.
Thank you, Madam Chair. I think the discussion pretty much covered it. I was just going to point out that there was no opposition at all to this bill.
Delegate Riley.
Thank you, Madam Chair. Yeah, and during the hearing, I believe Delegate Shetty had mentioned, she really liked the suggestion from the chair to make it an emergency bill because appropriations was currently looking at this, and they wanted to automatically now use the funds instead of waiting. And then originally, they had to wait like 2-3 years to give funds out.
Because
So
of
they
the
would like
RFP
to.
process
Yeah.
that was
So
identified.
that was one of them as well, because they were currently looking at it in the budget.
The chair wanted to make it emerge, thanks for Delegate Riley, so that we can get it out of their sights.
Thank you, Delegate Riley, for pointing that out. I appreciate you. So we are on the bill as, we did the amendments, we're on the bill as amended. Is there any further discussion on the bill as amended? All right, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Can we do a sponsor amendment for this one? We can, yes, because it's amended. Is there anyone who would not like to be on this bill? Delegate Shalega, Delegate Morgan.
I may vote against this on the floor. I'm going to do a little more.
Okay. Well, and I appreciate. Do you want to be recorded in the no for now? Oh.
I'm for leader on it.
Oh.
Don't worry, Kathy's on the committee.
All right. Well, so that passes not unanimously, no, it passed unanimously, sorry. And it's not everyone is co-sponsor, sorry. Thank you. And House Bill 747, this is Oversight Committee on Quality of Care in Nursing Homes and Assisted Living Facilities membership. This is Lisa and Lopez.
This bill alters the membership of the Oversight Committee on Quality of Care in Nursing Homes and Assisted Living Facilities by removing one Senate member and one House member to reflect the current committee structure and jurisdictions of both chambers. There's amendments on page 17 of your packet. The amendment removes 2 members from now defunct organizations, adds a member from Leading Age Maryland, provides that the representatives from assisted living facilities represent programs of different sizes to the extent practicable, and makes corrective changes.
Delegate Lopez.
This passed with no controversy, very little discussion, because it's very straightforward and simply updates and modernizes the membership of that commission,
Move the amendments.
or committee, rather.
Any further discussion on the amendments? All in favor say aye. Aye. Anyone opposed to the amendments, go ahead and raise your hand. A bill has been moved and seconded. Any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand.
I'm sorry. We're going fast, and I think I sit on this commission, Madam Chair.
Okay, go, Delegate Alston.
Okay, I am wondering, once we shuffle these people, what is going to be the makeup of this oversight committee? Because one of the concerns I have is that it's heavily dominated by people who have concerns about large organizations, and the smaller voices are not often heard in those meetings. So what will be the new composition?
Delegate Lopez or Lisa?
Yeah, I'll defer to Lisa on this, but to kind of encapsulate the changes, there were 2 defunct organizations that were listed that we took off, we included Leading Age, and then there were 2 senators and 2 delegates who were appointed, and we updated that to be 1 member of the Senate, 1 member of delegates. So if there's a broader concern about the representation of smaller organizations, that would be unaddressed by the changes that we're making.
I'm not aware, of the changes that are being made, that they would address your concerns. I don't know the sizes of but, I mean, it's the Health Facilities Association of Maryland, which no longer exists, and Voices for Quality Care. Those are the 2 organizations that don't exist.
Okay, thank you.
Do you have further concerns, Delegate Alston?
No, I don't.
Delegate Lopez, you had your light on.
I'll just move the bill if it hasn't been moved. Was it moved? Okay, never mind. Just kidding. I withdraw the motion.
All right, so we moved the amendments, we voted on the amendments, we moved the bill. This was our discussion on the bill as amended. Any further discussion on the bill as amended? All right, seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. It passes. Is there anyone who does not want to be on the bill? Raise your hand. All right, everyone's on. All right, we are now, I just wanted to say, I got some clarification from, on House Bill 672, the Public Health Maryland Pediatric Cancer Fund entities eligible for grants. To Delegate Shalega's question, physicians affiliated with research institutions are eligible. Private practice physicians who are unaffiliated with pediatric hospitals aren't the ones doing the cancer research. So that's why that language change was added. And we are now on House Bill 813. This is Maryland Medical Assistance Program coverage for the treatment of obesity. And this is Christopher and Hill.
This bill authorizes Medicaid beginning January 1st, 2027 to provide comprehensive coverage for the treatment of obesity, including coverage for intensive behavioral therapy, bariatric surgery, and any medication approved by the FDA with an indication for chronic weight management in patients with obesity. Medicaid may undertake utilization management to determine medical necessity and appropriateness if the determinations are made in the same manner as for the treatment of any other illness, condition, or disorder. If coverage is provided, the Maryland Department of Health must provide notice to Medicaid recipients. By November 1st, 2027, MDH must report to specified committees of the General Assembly on whether Medicaid has begun to provide comprehensive coverage for the treatment of obesity. There were a couple of amendments from Delegate Martinez, which is before you on the separate page with the star. And this amendment is Delegate Martinez's amendment with an additional thing from Delegate Hill, but I'll explain it. So the amendment is technical. It alters the short title and the purpose paragraph, but it adds language to require MDH to apply to the Centers for Medicare and Medicaid Services for a state plan amendment authorizing the state to provide coverage for the treatment of obesity. And this is just helping to clarify that this is an authorization, not a mandate. The only difference with this in front of you is that Delegate Hill added to the title of the bill authorization to help make it more clear that it's just an authorization and not a mandate for coverage.
Delegate Hill.
Yeah, so we had a good discussion. There was one person who did not vote for the amendment. It was Delegate Riley. And then on the bill itself, both Delegate Riley and Hutchinson abstained. So the bill passed, but not unanimously. So really, as Chris presented, a single amendment, but there are really two. There's the amendment that was passed by the committee, and then there's the standalone amendment that I will offer here to change the title, because we've, based on the discussion that led to sort of the neutral votes, there was, again, the bill reads that it authorizes the department to start looking at, and they can make a determination about whether to cover these drugs. The way the title reads, people think that it is actually mandating or requiring that the Department of Health do this. And so with that, I would like to move first Delegate Martinez's amendment that was taken up by the committee.
And that's, just to clarify, that's amendment number 2 as we're looking at it on the page, correct? Okay, so this is on the amendment that was already adopted by subcommittee. It's been moved and seconded. Any further discussion on the amendment that was moved by subcommittee? Seeing none, all in favor say aye. Aye. Anyone opposed? All right, and then Delegate Hill, do you want?
Discussed in the subcommittee, and that would insert the word authorization in front of or after obesity, so that it would read, where am I? Authorization of coverage for the treatment of obesity. As the title. Right, as the title.
All right, it's been moved. Do we have a second? All right, it's been moved and seconded. On the amendment, is there further discussion? All right, seeing none, all in favor say aye. Aye. Anyone opposed? Go ahead and raise your hand. This is the amendment that was just offered. So do we want to move the bill as amended? All right, it's been moved and seconded. Now we'll open it up on the bill as amended for discussion. Did you have a Delegate Shalega, did you want to?
Yes, so this is just going to make it a study as we do other things to find out how much it's going to cost?
Well, I think it is to apply. Right. So they can apply for a waiver to see if they can fit it under the HEAD model. They can look at ways of doing this and make a determination as to whether this is something that is in the best interest of the patients who are covered and in the best interest of the state. I wouldn't call it a study, because a study implies that there's a report out. This is just sort of directing and authorizing MDH to look at whether we should be covering this. And I think maybe Delegate Martinez can explain better.
Let me go to Delegate Martinez.
Thank you, Madam Chair. So this is not a study, Delegate. The reporting factor is just whether or not they apply for it and actually implement it. They'll report back to us that that is what they're going to be doing. That's the reporting requirement in the bill. The reason why we're doing this as well, and the manner that we're doing it, is because the Centers for Medicare and Medicaid are already looking at what they're calling the balance model. You can look at the fiscal note on additional comments, where it outlines that the federal government's already looking at negotiating with manufacturers around the GLP-1s and trying to lower cost. And so if that is something that happens and we are not here, then they will already have the authority to move forward to give our residents cheaper weight loss options. Right now, there is no ability, if the feds were to come back and have a change in how we have cost, or just how our partnerships with the manufacturers are, because right now in our plan, we prohibit any coverage of obesity, period.
So are you saying that if Donald Trump lowers the price of Ozempic, this will allow people, insurance companies, Medicaid, to provide it?
This would allow for our State Department to put in an amendment to the Medicaid plan to cover obesity coverage if there is an ability to afford it.
And then who decides afford? Sorry for the questions, but I noticed that Howard County Public Schools announced it will end coverage of GLP medication because it ended up costing them so much. So
with the current, cost of things, I can see why that is the case. But because of the ongoing work that's happening on negotiating lower prices, there could be a different reality when we're in the interim. And so all this is doing is saying that by next January, that they have to submit a a waiver to the federal government in order to cover obesity treatment. And if there are actually things that they want to do once they've submitted that, then they have to give notice to all Medicaid recipients and then send a report back to us later that year that they've done this.
So could it increase the cost of Medicaid? Yes, or how is it going to directly affect the cost of Medicaid?
The way the bill is currently written, there is no impact unless action is taken past the authorization. So past the waiver being approved, they then have to come up with what the cost will end up being. There will be an impact at that point. But as of right now, with the way the bill is, it's just enabling the agency, the health department, to submit to the feds a amendment to the plan.
Delegate Hill. Delegate Hill.
Thank you, Madam Chair. The department still has, I'm not sure if I heard in your question, but it seemed like there might be a concern that the department would be able to put money out for this without our say-so. They still have a budget they have to work under. And so they can't do anything that costs more than their budget allows without our appropriating more to their budget.
Thank you. I think where I was going, look, I felt terrible, with the scalp cooling and the prosthesis, but saying if we're going to vote against things that raise the cost of Medicaid, I'd be hypocritical if I voted for this when I voted against those other things. So that's my line of questioning. So you're telling me right now it is not going to raise the cost of Medicaid. It's just going to allow options if the drug cost is lowered.
Exactly.
Okay, thank you.
Let me go to Delegate Morgan. Hutchinson's light is off. Okay, Delegate Morgan, then Alston, then Gazzone.
I'm going to try to sum up some of the members of the minority party on this committee's concern on this, because we got into it a couple times on this bills. So they write a fiscal note with the actual, what is the amount of money it's going to cost right here and there. And the problem with fiscal notes is it's a snapshot in time. It doesn't count for dynamic scoring and cost savings picked up on the other side, nor does it account for things that might be wrong in the future. And just some of us are a little bit skeptical of government, my side likes to question government, that they come out and do these things for the best intentions. And then 2 or 3 years later, you start realizing that it's not really lived up to what the experts say. And then we're still stuck with the bill. And then the people that are wrong never pay a consequence for being wrong. So I think that's just our tummy ache that we're having on some of these bills now. So with that being said, I don't want to belabor the point or anything, but I just wanted to get that statement out there.
No, we appreciate the discussion, and to your point, this is a snapshot. To Delegate Shalega's point, we don't know what the feds are going to do because they are very interested in a way to make these pharmaceuticals affordable and accessible. So this would allow us to consider that accessibility outside of the interim. Outside of the session. Is that correct?
Your point, Madam Chair, these drugs are still being developed. But like the technology is changing at a rapid rate on this, because the drugs that we've heard the last couple of years on bills similar to this, those were off-label use drugs. Now you're starting to get stuff that's designed directly for this. So who knows what the future could hold. Hopefully technology will save us and save us a lot of money, but there's just some skeptic.
I appreciate that. Delegate Alston.
Yep, I was just going to say, with all of these waivers, we don't know what the cost is going to be, but they take it from existing resources. So it's not an expansion because the budget has already been allocated, similar to what Delegate Hill was saying. So I just wanted to say, with all of the 1115 waivers, it's the same process. And with most of them, the advisory board can do it on their own without coming to the General Assembly. But in this case, they couldn't even look at it because of the restriction in the law. So the budget won't change because Medicaid only gets so much money. They would have to reallocate their resources internally in order to make it happen or ask for more appropriations from us. So I get what you're saying. One of the things that's also not captured are all of the things we pay for people who are obese, like hypertension, diabetes, the litany of other things, and that's never captured in the notes either, because that is certainly more expensive than whatever these GLP-1s cost in order to prevent. Maybe. Well, we don't know what 30 years is going to bring, but as of right now.
And you don't know the repercussions of taking these drugs, the side effects, and how that affects certain populations. So I'm just saying that sometimes it's a safer bet to wait and see. Now, I know the federal government is trying to do their best to try to lower, and look, they've made great progress at that most favorable nation status and forcing these drug manufacturers and PBMs to sell these latest, greatest designer drugs, really, at a more affordable price. And I'm not saying that the future, hopefully that's where it's going. But sometimes it's a better wait and see, because once we make that decision, we're stuck with that decision.
And Delegate Martinez, is there a cross-file on this bill?
The cross-file of this bill is Senator Hershey.
And do we know the status of the Senate bill?
I have not checked to see if it's on a vote list, but there was not as much conversation on the Senate side.
Okay, thank you very much. And Delegate Gazzotti.
Thank you. And just a quick point of reference, I had discussions with Department of Health earlier this year regarding an 1115 waiver. And they said at that point that getting responses back on waiver requests is at very minimum a year, more likely 2 years. So this is going to take a while just to get approval of the waiver. And so I think it's reasonable to move forward with it. It also doesn't mean that we actually have to ever activate the waiver. We just have the ability.
Yeah, it just starts the process. Delegate Riley.
She just answered my question. I was going to question the waiver, the process of the waiver. And does it come back to us as the General Assembly to vote on that, or whatever the agency comes up with? You know, once they get the report, they make the decision instead of bringing it back to us. Is that correct? Okay. All right. Thank you.
Oh, Delegate Hutchinson.
So is our state drug affordability board looking at obesity drugs?
Drugs they're looking at.
That they're going to look at is Jardiance.
I'm sorry, which one?
Jardiance. I'm sorry. The first drug that they're looking at is Jardiance. The second one is Farxiga. I don't think Farxiga is one of these GLP-1s, but Jardiance is.
List, 6 of them were GLP-1s.
And so if they were to lower the price of that drug, does it affect this bill?
I believe it still allows, basically what we're doing is allowing the department to continue to look at the issue and to act if it gets to the point that they think that there are cost savings and that, you know, within their budget, they can do this, right? And, you know, so we saw what the feds did essentially by putting a brand on what is GoodRx and seeming to lower those rates. And they may do more. But the main thing, and that's the point both Delegate Martinez and Austin were making, the way the law is written, if we don't pass this bill, we can't do anything. It doesn't matter. So the idea is to have the flexibility to help to deal with what we know is a significant health care problem, has sometimes been called an epidemic here. And we cover these medications for diagnosis of diabetes, but we don't cover it for obesity per se. And so all the unknowns are there, which is why we come back every session to try and fix things that we didn't know were going to do the things that they ended up doing.
And just to give a little context, because it is a little bit different between the private carriers and Medicaid, but the waivers demonstrations usually also are identifying the cost to the state, but also any potential federal match dollars, so that we have a full understanding of the impact. And as Delegate Gazzoni said, it is not a short process. It's not a short process. So is there any further discussion on this bill as amended? All right, seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. We've got Delegate Shalega, Delegate Morgan, Delegate Riley. All right, this is favorable with amendment. So is there anyone who does not want to be on this bill? Delegate Shalega, Delegate Morgan, Delegate Hutchinson, Delegate Riley. Delegate Kipke's not here, so it's not. But. All right. Yeah. Oh, and Delegate, yeah, and Delegate Delegate Taveras and Delegate Warman are not here, so we want to make sure that that we're reflective of who is here. House Bill 860. This is Petitions for Emergency Evaluation, Arnaud and Magruder Memorial Act. This is Christopher and Hill.
This bill clarifies that an endorsed petition for emergency evaluation is effective for 5 days after endorsement and authorizes a court on a motion by the original petitioner and for good cause shown to extend the effect of an endorsed petition by 5 days at a time for up to 30 days based on the presenting behavior of the individual. Each extension must be based on a separate motion. An endorsed or extended petition must be served expeditiously, and the court must include on the petition the date the petition expires. A peace officer must act in accordance with the Maryland Use of Force statute when executing a petition. There were a few amendments. The First Amendment, which is on page 18 and 19 of the packet. The First Amendment is technical and alters the purpose paragraph. The Second Amendment does a few things. It clarifies that an extension of a petition may not exceed 30 days from the starting, starting from the date the petition was originally endorsed by the court. Good cause must be shown and the initial petition's grounds must still exist. It requires a court to include the expiration time on the petition in addition to the expiration date. And it authorizes peace officers to act with best practices on how to take an emergency evaluee to an emergency facility and elect to be joined by a mobile crisis team when practicable.
Delegate Hill.
Right. So Delegate Austin did a yeoman's job of coming up with amendments that judiciary could agree to, OPD could agree to, although that does not bring them to neutral. It brings them to being satisfied that this is the best we can have right now. Okay? And with that, I move the amendments.
Second.
All right, amendments have been moved and seconded. All is discussion. Delegate Morgan. Oh, not on the amendments. Okay. Any discussion on the amendments? All in favor say aye. Aye. Anyone opposed? Go ahead and raise your hand. On the bill as amended. It's been moved and seconded. Delegate Morgan.
Question, I guess, for the bill sponsor, maybe floor leader. What qualifies as an emergency evaluation? Like, what is the is it public safety or is it safety to themselves?
Safety to themselves or others. So if they are a threat to their own safety or the safety of others, then they can be emergency petitioned to go to the hospital to get medical care.
And this has to be, it falls under just for mental?
Yeah.
Not like,
I don't understand. Yes, it's usually a mental health issue.
okay. I'm just wondering, because I mean, I don't know, have a law degree, obviously. But, I mean, we ran into discussions with the, on the 287G bill about people being held more than 48 hours on an administrative warrant that had past criminal records. And I was just wondering, if one's illegal now, is this, you see what I'm saying, that now you're holding somebody for 30 days?
Yes, I understand the question. So the, you wouldn't hold them for 30 days. When they go to the hospital determines how long they can hold them because they're going to get medical treatment. Usually on mental health holds, it may be up to 72 hours, or sometimes they get them and release them right back out. So it really just depends on how long the hospital determines they need to get the person stable, how much treatment they need.
Okay.
But the 30 days is the amount of time to get them served, because you have to serve them with a copy of the petition or the order to take them to the hospital. And so what happens in a lot of cases, if a person is homeless, you may not know where to find them. And so the 5-day extensions at a time is to try and find that person who may be absconded or is, difficult to find because their mental disorder is maybe telling them to do things. Yes, absolutely. Great question.
Yeah, thank you for the clarification. Delegate Hill.
Yeah, and Delegate Austin, could you explain for all of our understanding why extending it 5 days at a time is more appropriate or appropriate to the situation than starting an emergency petition process all over again?
Yes, because one of the things that we found when we did the work groups is that there were people who would literally Xerox the same petition and take it back in. And after the 5 days expired, they would just go back in and ask for a new petition. And the court, because you would get a different judge, would have no way of knowing that this is a recycled petition. By doing the extensions, the court actually gets to see the original petition. The person has to provide testimony as to why it wasn't served in a timely fashion and provide testimony that this danger to life, health, safety of themselves or others is still actually going on. So I think it's a higher standard, even though the public defender's office disagrees with me on that. I think it's actually a higher standard of proof because they could just go get another one and Xerox their petition and most likely get it granted. Whereas with this, you have to show that why you couldn't serve and why for however much time they've been able to survive in the community, but the behavior is still there.
Thank you. Any further discussion on this bill, on the bill as amended? All right, on the bill as amended, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Is there anyone who does not want to be on this bill? Go ahead and raise your hand. Yeah, that's fine. Delegate Shalega, Delegate Morgan. All right. And Kipke is not here, but Delegate Tavares and Delegate Mormon are back. And this bill will not be, reported out because judiciary is second on the bill, so it still has to be voted out by judiciary. Our final bill is House Bill 88, no, not our final bill, because we're going to circle back on that one bill. So House Bill 882, this is the Consumer Health Information Termination Date and Mandatory Funding for the state's Consumer Health Information Hub repeal. This is Christopher and Hill.
This bill repeals the June 30th, 2026 termination date for the state's Consumer Health Information Hub and the $350,000 mandated appropriation to the hub. Instead, the hub must operate to the extent funding is available. The bill takes effect June 1st, 2026, and there were no amendments.
All right, it's been moved and seconded. Is there any further discussion on this bill? Seeing none, all in favor say aye. Aye. Is there anyone opposed? Go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Hutchinson, Delegate Riley. That's fine. It's
Where we got here, and I didn't quite understand. We're talking about the hub, right?
Yes, we're talking about, is this go ahead and ask your question. There was just, yep, go ahead, Delegate Hill.
So on this bill, I know it's getting late, there was discussion about the hub, and there was concern raised by Delegate Austin, who abstained, about if we aren't going to fund it, and we think this is important, why would we not fund it? And so we got information about that I can share, but I shared it with the subcommittee. So I can share it with the committee, or we've already shared it with the subcommittee. I think Delegate Austin has been satisfied. And so we can move forward with the bill unless, Madam Chair, you want us to.
We can just have the discussion. I know there was a question about the funding, and we did hear back from the Department of Health.
We asked the Department of Health why they were agnostic about the funding, and it turns out the funding doesn't come from them. It's actually in the University of Maryland's budget, and they're fine, and they've got the money for this next year already in there. They're not concerned about it. So it will be funded for FY '27. It's not a Department of Health funding problem.
All right, and we've moved the bill. Let's go ahead and just do it again because we've had the discussion. So can I have a motion on the bill?
Move the bill.
All right, it's been moved and seconded. Any further discussion? Delegate Hutchinson, do you still have a question?
Let's go to.
All right. All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Hutchinson, Delegate Riley. I appreciate that, absolutely. And we understand and appreciate philosophical differences in this committee. So we wanted to go back to House Bill 494, Health Insurance Primary Care Investment Targets, Reimbursement and Reporting. This was Lisa and Cullison. Yes, Vice Chair Cullison.
Okay, so I think I'm going to explain it, and I apologize that I didn't know about the executive order. I assumed it was all about the AHEAD model. But basically what this is designed to do is to make sure that that folks are going to get primary care, and they're going to do that by saying to the payers, in fact, while we've been sitting here, I just got a message from my primary care doc saying, you're due for a wellness check. So my primary care doc is on it. And the payers, so they're going to set targets as a percentage of their overall spend. And we don't know what that is yet. And that's why MDH and MIA and MD and HSCRC and MHCC are all looking at what the total spend is and then set a percentage of that as the target for primary care. They're not going to hit it the first year, probably, because they won't have done the work that they need to get there. So your question is, could that potentially increase healthcare premiums? Depending on what the target is, it could. If the target is something that is easily within their spend and they're directing people soon enough, then it won't. But I have to be transparent and say, yes, it could.
Delegate Morgan.
I was a little, because I knew, going back to the hearing and whatever, but basically the state's going to, as a policy prescription, is going to come up with these targets based on the amount of money the carriers are spending. Now, I guess it's the same argument that we were talking about, the same concerns with the dynamic scoring. We want people to go to their primary care because we think that lowers health care across the entire sector because you pick up stuff early. But the same token, these higher targets will result in higher rate increases. And when the higher rate increases happen, more people will go to Medicaid, which is even more of a state money. That's reflected in the fiscal note on the last page. It says likely increases for Kaiser by at least 3%. So that was the concern and everything. So with that, we can move the bill, but we're good. And I appreciate you moving it back and everything, explaining. We should completely understand.
I appreciate you raising.
All right, so do we have a motion on the bill? Do we have a second?
Second.
All right, it's been moved and seconded. Any further discussion on the bill? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. We've got Delegate Shalega, Delegate Morgan, Delegate Hutchinson, Delegate Riley. Thank you very much. This concludes our voting session. Just let us know when we're down. Thank you.
I'm sorry. Chair, are we holding Austin's bill?
It's got to go to judiciary. Judiciary is second on that. Yeah, so it just won't be reported out yet. These will most likely